All right, welcome everyone to the University of New Mexico Law and Mental Health Didactic Series, hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. We're so excited to have so many of you joining us here today. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico's Department of Psychiatry and Behavioral Sciences. For our talk today, if you have any questions for our presenter, make sure you ask them in the Q&A box anytime you feel comfortable. We do hold those off until the end. We do try to get to as many as possible. A lot of times it's not possible to get through all of them, so just forgive us if we cannot get to your question. For those of you that are pursuing continuing medical education credits, there will be a sign-in sheet in the chat right now. It should be right there for you to see. For those of you that are pursuing APA continuing education credits, that will be posted in the last 5 minutes. You will have to open up your link and save your certificate after you've completed the survey, because we don't have access to that, and we at UNM do not keep copies of this. As a heads up, a recording link and PowerPoint slides for this talk will be available probably sometime later today. And next week's talk in the series will feature Dr. Lauren Gonzalez, who will be covering social determinants to promote mental health equity. But now is the time that you've all been waiting for. I'd like to introduce you to today's speaker, who will be discussing the overarching issue of psychopathy, which is very prevalent in a lot of forensic issues. This is Dr. Wen Gu. Dr. Wen Gu is a licensed psychologist in New York and New Jersey and an authorized practitioner through PsyPact. He received his bachelor's degree at Boston College, his master's at John Jay College of Criminal Justice, and his Ph.D. at City University of New York Graduate Center. As a certified clinical trauma professional, he supports trauma survivors lessen the influence of painful past events through emotion regulation skills and trauma narratives. Dr. Gu provides evidence-based psychotherapy, as well as conducts forensic and psychological evaluations for education and immigration cases. In addition to his private practice, he teaches as a clinical assistant professor at Icahn School of Medicine at Mount Sinai and as an adjunct faculty at Fordham University. Dr. Gu, it's great to see you. And on behalf of the University of New Mexico, let's just say we're excited to have you join this series and thankful that you'll be sharing your expansive expertise with us today. I will go ahead and throw it over to you.
All right. Thank you so much for the introduction, Anthony. It's been a while. Anthony and I attend the same graduate school program, so it's always nice to see a fellow alum, doing different things in the world. So the talk, I think the biggest challenge for me is trying to fit in the content of psychopathy or psychopathic personality within the confines of 1 hour. My goal for today is to give an overview of some of the construct issues, the ways that it's been conceptualized, and with a focus on the Hare psychopathy checklist. But by no means do I attempt to try to teach assessment of psychopathy within an hour. I think doing so would be me doing the field a particular disservice. And as Anthony said, I'll do my best to wrap up my talk 10 minutes before the hour so that there'll be plenty of questions, and I'll do my best to address them when they come in. Okay, so I'll go through some of the earlier slides that Anthony mentioned already. And the learning objectives for today is, to really talk about the construct of antisocial personality and the way that psychopathy is sometimes understood within those confines. The DSM-5 would be a focus because there is if there's anyone who's not taken a look at the section 3, also known as the alternative models of personality disorder, it sometimes does a very good job of describing the construct better than only the what's formerly known as the Access to antisocial personality disorder criteria. And finally, to explain the Hare psychopathy checklist scales and its controversies as well. Okay, so going to get into some of the frameworks around psychopathy, the different psychopathy skills, and also the practical problems and the implications. For those of you who were, I guess, a few weeks ago in attendance of the personality conference at Society Personality Conference in Austin, Texas, it seems like one of the major areas of focus currently is on clinical utility. And I'll talk about the relevance to that. Okay, so one of the first things that I want to point to is the very definition of what a personality disorder is. And within the DSM, I have the page numbers listed for you, is one of the definition includes that it's an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, right? So within the definition, and culture and norms is implied, and it would And you would expect to see dysfunctions not only in the cognitive world, but also in the affective, the interpersonal, and impulse control. Okay, so when we talk about personality, it's almost impossible to talk about it without understanding the broader context in which this particular construct is understood and also evaluated. The section 3 section of the DSM-5 that I mentioned earlier, also known as the alternative model of personality disorder, really takes these particular steps in trying to assess personality. And for those of you who are familiar with the psychodynamic formulations, or if you're familiar with Otto Kernberg's formulations of personality, this step 1 is actually very apropos to what Otto was talking about, where he was talking about problems with identity and self-direction, right? Problematic levels of functioning with interpersonally with regards to empathy and intimacy. So within the DSM-5, there is actually a way to gauge different severity of personality dysfunction at those domains as well. In step 2, right, the idea is to assess the pathological personality traits that is on the 5-factor model. So the labels and the scales may look different than probably the NEO-PI, which is what many people are popularly used, but they map onto the 5-factor model using the factors of negative affectism, detachment, antagonism, disinhibition, and psychoticism. Right. And as I proceed through the talk, I want you to come back to this particular slide in your mind, if you can, and go, if I'm really trying to understand the construct of antisocial personality disorder, where are the elevations expected? Right. And now within step 3, they talk about a proposed, they used to call this prototype matching, but it's the idea that there's 6 personality disorders for which we have pretty good idea of how the traits might line up. Okay. And finally 4, right, looking through whether there's problems with flexibility and pervasiveness, because the understanding of personality disorder, it tends to be enduring over time. And so it's not only a function of situational factors that may change one's functioning from one setting to another. Okay, so here on page 764, right, here are the proposed diagnostic criteria specific to antisocial personality disorder. Okay, so not going to read through all of it, right? But the idea that this is an individual who struggles with identity, whose self-esteem derives from personal gain, right? The idea that within the construct of the self, goal setting is based on personal gains and the absence of pro-social internal standards or collaborating with others, right? And within the construct of interpersonal functioning, the lack of empathy or concerning for how one's action might affect others. And finally, intimacy, right? Can we actually have mutually intimate relationships, or is this a person whose exploitation is the main focus, right? So within even the levels of personality functioning, you see within those 4, there's some expected direction with which this particular construct holds. Now, within the particular traits, one does expect manipulativeness, callousness, deceitfulness, hostility, risk-taking, and impulsivity, right? And as you think back to the 5-factor model, right, the 2 main factors on which this loads is on an increase in antagonism and also disinhibition, right? So this is talking about 6 or more of the following 7 pathological personality traits. The 7th one is here, right? Irresponsibility. But basically, if you look in the language or in the parentheses, you basically see elevations on antagonism and disinhibition that is expected to be higher than the norm. And finally, if you keep reading, right, there's a specific page that's devoted to with psychopathic features. Okay, so even though they're using DSM is calling it specifiers, they define psychopathy, often termed primary psychopathy, as a distinct variant of antisocial personality. Okay, so if any of you continue the if any of you are called to the witness stand to talk about this particular construct, and you may have an attorney who says, or who may have partially read the DSM, who says, isn't psychopathy not part of the DSM? The answer is definitively it's absolutely part of the DSM. It's both part of the AMPD section of the DSM-5 and also within the criteria as well, and I'll show that in the following slide. Okay, so I mentioned before that the focus of a recent conference, the Society of Personality Disorder, they were actually talking about what is the clinical utility of personality assessment, right? They were thinking more broadly with respect to how does it benefit the person making the referral? What is the evidence if a client actually asks, why are you assessing personality? And what are does it inform treatment? Does it change the way that psychotherapy is delivered? Does it change the way that we understand a particular issue so that the management will be different? Well, one of the major benefits of forensic psychology and also forensic assessment is that the clinical utility was very much baked into many of the creation in the assessment of certain construct, right? So within the construct of malingering, there are specific tools that have been developed to better assess malingering so that we clinicians are not only relying on our subjective feel for what might be happening, right? It's very powerful to be able to talk about whether somebody may or may not be engaging in exaggeration or fabrication of psychiatric symptoms based on the fact that they might be scoring in a range that is highly improbable compared to what we know about how psychopathology works. Within the construct of psychopathy, right, we do, the court is both the court and also clinical use is very much concerned about malingering because we know that individuals higher on psychopathy have a higher tendency to be deceitful and distort the truth. Okay, so to the question of what is the clinical utility of knowing whether somebody might be higher on psychopathy, the answer is it actually affects these very major areas that psychopathy has been linked to, which includes deceitfulness, which includes increased incidence of violence, both in the institution and also in society, right? Sentencing decisions have also been made based on one's psychopathic scores from the point of view of whether somebody is more likely to recidivate or reoffend. And in some of the recent conferences, there's concerns about fraudulent behavior, right? Academic dishonesty that is also very much tied within this specific construct. So to answer the question that more general personality assessment individuals were asking, well, the clinical utility of knowing whether somebody is psychopathic or high on the construct of psychopathic is actually quite relevant. It actually changes a lot in terms of how we engage with that individual with regards to management of risk, and with regards to whether we expect certain difficulties, whether in institutions or not. Okay, so here is where I take us back a little bit to Jane Murphy's 1976 work, who was studying the Inuits around the Bering Strait, who also had their specific terminology for men who lie, cheat, steal, take sexual advantage of women, and do not care about punishments, right? So to the question of how is this something only to, specific to the Western culture? It seems like there's anecdotal evidence and plenty of other epidemiological evidence that these individuals seem to exist in different parts of the world, regardless of technological advances or cultural differences, right? And the Inuits' way of dealing with these socially deviant individuals was to quietly push them off the ice, right? They basically put them on a separate iceberg and let it drift away, right? It's their way of distilling capital punishment. Okay, so there is something about a recognition that there are a small percentage of individuals within society who somehow don't conform to societal norms and do so in such a consistent and perpetual way to be disruptive that they don't believe that those individuals could be rehabilitated. Okay, so right now I'm going to sort of jump back and forth of the frequently asked questions, right, are at least within the the layman's questions are psychopathy and antisocial personality different things, right? You probably may have had family members or even other clinicians ask about what are the differences between psychopathy and antisocial personality, right? And the answer is they're often used linguistically similarly. And conceptually, there is this idea that we're talking about similar things. But there is a big difference, and I say slight, but there is a difference in diagnostic criteria. The reason I said slight difference at one point and a larger difference is depending on what criteria of the DSM-5 you use, the difference could be bigger or smaller. Right? A second frequently asked question is, how can psychopathy be diagnosed if not listed on the DSM-5 or the ICD-10 and now ICD-11? And the answer is, it isn't there. Right? So I actually marked the specific pages for you so you can actually see that the DSM absolutely talks about psychopathy. It does so sometimes using the language of specifiers, okay, but both in the DSM-5, in the DSM-5 TR, and also in the ICD, the International Classification of Diseases, they talk about it in the context of dissocial personality disorder. So linguistically, we're talking about the same thing, okay? Within the world of sociology, right, they use the term sociopathy, okay? But know for you that linguistically and conceptually, we're talking about the same thing. But where are the differences? And, in terms of what is the etiology of psychopathy, I would say, depending on who you talk to, the answers might be very different. And etiology is probably one of the things in psychiatry that's the most difficult to discern, right? If you talk to sociologists, they'll say we need certain individuals to be higher on sociopathy because of the various ways in which they also impact society, okay? But in terms of where the construct overlap, okay, so I'm going to keep this particular chart up for a little bit. If we're only looking at incarcerated populations, right? 78 to 80% of incarcerated populations meet the criteria for antisocial personality disorder. If you're using, right, the current criteria that says if you meet at least 3 out of these 7 specified or criteria, you meet criteria for ASPD, okay? Now look at the second part, which is, and amongst those, right, 20 to 25% meet criteria for psychopathy. So at the very least, we can say psychopathy is a variant of antisocial personality disorder, suggesting that not everyone who is antisocial, right, meet criteria for psychopathy, but there is enough overlap for us to talk about, how they are relevant. This particular chart also looks at factor 1 and factor 2 scores that I will go into a little bit later as well, because these are specific to the PCLR, also known as the psychopathy checklist. But they're basically talking about this idea it is understood as a variant of antisocial personality disorder that tends to lead to more problematic outcomes. The major models or mechanisms of psychopathy, there's actually 3 major ones. The first one is the one that prioritizes or understands fearlessness and dominance and Machiavellian, the negative triads by Icahn, right? And Icahn was also the mentor of the late Scott Lilienfeld, who authored the measure, the psychopathic personality inventory. Okay, so all these models look at where the problematic mechanisms may be occurring and where the problems might be. For Bob Hare, he was really looking at the hypo-emotionalities, right? So the lower emotional responses that can be actually traced back to a lot of the work by Cleckley, which I will get to a little bit as well. The cognitive disinhibition model by Newman. So this is not the Craig Newman that often works with Bob Hare. This is Joseph Newman, who looks at impulse control and decision making. So if I ask the audience, right, sort of a rhetorical question of when we talk about, where do people focus their attention? Where did they focus their where do they attend to, right? If you think about all of the neuroimaging studies that are often done as, well, how do they impact decisions about judgment? How do they decision about reward? A lot of the model on cognitive disinhibition actually goes in that very direction. And conceptually, right, it's sometimes easier to understand the hypoemotionality model if I ask a more broader question, which is what happens, right, if one is simply born with lower anxiety, and what that looks like in a child, what that looks like in an adult, how it impacts long-term, short-term judgments and risk and reward judgments. Okay, so if I, sort of pause here for a second and ask you to think back to, can you think of individuals in your life that simply has very low anxiety for any number of reasons, and then think about their actions as a child, as an adult? I mean, a salient example that comes to mind was during my days working on the inpatient unit. We had a patient who was 10 years old at the time, who was brought to the hospital because he was endangering his younger siblings. And what he was doing was pushing his, infant sibling off these really high chairs that, infants often sit in. And he was doing so repeatedly, right? So getting into trouble repeatedly. And some of the questions that we would ask is, what did, what did you think was going to happen, right, when you pushed your brother off this high seat? He said, well, I thought he was going to fall, right? And that he was going to get out of the chair, right? So almost this very, very, very specific focus on the empiricism of the action, and also being completely off with which he anticipates another person's perspective and reaction. So when people talk about, oh, there's a coldness with which, certain individuals behaves, that's where it's coming from. It's actually coming from a place of complete lack of understanding, or being so off with how one anticipates somebody might be thinking or feeling, that actually strikes one's notice, right? In terms of what happens when one has low anxiety as an adult, right? You might be able to imagine the kind of activities that they're more prone to doing, not necessarily criminal behavior, but any sort of high-risk behavior that you can think, whether it's being completely okay driving 100 miles per hour on the highway, right? And knowing that, hey, my heart rate doesn't really increase at that particular speed, that I'm still able to do everything I need to, while at the same time recognizing or not recognizing, hey, how does driving 120 on a road that's meant for 75 or 65 could impact other people on the road, right? You might even think of people who do free climbs. Basically, those are individuals who climb mountains without safety harness, right? And why would one do so? Because presumably, right, there are other ways to climb without having the same impact or without the same risks. But I like to always ask these broader questions to get a sense that we do actually see this phenomenon probably more often than not. So then the question becomes, does low anxiety necessarily predict, right, bad outcomes? And the answer is not necessarily, right? But we do think engaging in more risky behaviors might result in worse outcomes. So within the family of the Hare psychopathy scales, the first one was created in the 1980s. And by the way, Bob Hare was not a clinical psychologist when he was developing these measures. He was hired as a research psychologist in the prisons in British Columbia, right? It was further revised in 1991 and 2003. In 1995, actually, one of Hare's students, Steve Hart, developed a screening version of the psychopathy checklist. And I always say, and probably Hart would definitely agree, that the screening version is probably a misnomer, because it actually does different things. I'm not going to get into the exact nature of is this, MMPI-2 RF versus MMPI-3 kind of territory, but or MMPI-2 versus RF territory, like discrepancies. But as I'll have a slide showing later, the screening version actually has completely different norms, which means that you can use it on a much broader population than the PCLR. There is a youth version developed by Adele Forth. The P scan and the B scan I've almost never seen outside of research and academic settings. And so the focus of the rest of the talk will be on the PCLR. Okay, so in terms of how Cleckley, how Hare developed the measure, a lot of his work was based on the work by Harvey Cleckley, and especially the work, his work Mask of Sanity, right? So Mask of Sanity, by the way, it is completely free. If you even do a Google search on what it does, or different version, I am certain there's a free version of the Mask of Sanity that you can read up on. So you can get an idea of how Cleckley was thinking about this construct even back in the 1940s. And Cleckley emphasized personality features rather than behavior. Okay, and Cleckley made a big mention that it was not initially intended as a risk assessment tool. He really wanted to capture, I guess, the behaviors and the features of these individuals who he found fascinating because they keep getting themselves in trouble, right? So if you think back to the definition of personality disorder, there's something self-defeating in one's functioning where it's not a helpful or a functional element. Cleckley did emphasize the emotional deficit model as being the problem. And his book is basically a collection of case studies. I think it was about 15 or 16 case studies that he put together describing the actions and the histories of the individuals that he was seeing. But the point that Cleckley made was those individuals may engage in criminal activity, but it's certainly not a guarantee. In fact, he would argue that most of these individuals that he was looking at for case studies were not sampled from incarcerated settings. It was not a prison or primarily a forensic population that he was studying. He would argue that most of these individuals either charm themselves out of major problems, and they're usually not emotionally involved enough for very serious or sadistic acts. So if you think about how psychopathy is understood currently, right, it seems like we have shifted from how Cleckley was understanding this particular phenomenon, right? And with regards to this particular work, right, there was a clear delineation that I highlighted for item number 2, which was he wanted to make sure that those individuals are separated or have divergent validity from individuals who might be psychotic, right? So I know that, even in presentations, I've seen presenters sometimes say, psychotic instead of psychopathic, and, the similarities in the linguistics, but he really wanted to let people know we're not talking about individuals who behave so seemingly illogically that they're having poor reality testing. This is not, right? But that there's a specific characterological traits that he proposed 16 of them, where he's seeing this pattern where there seems to be a really problematic emotional deficit, right? And also the behaviors that accompany it. So in terms of what the Hare psychopathy checklist looks like, the PCLR can be completely done only using a chart review. In fact, they would argue that you can do it sometimes without the clinical interview. They much rather you have very good data and information of historical information as opposed to being too biased by interpersonal information. It's a 20-item test that loads onto 2 factors. Sometimes, the debates in the academia world debates whether it's 2 factors versus 3 factors. But basically, it's dealing with the factors of emotional and interpersonal problems and behavioral and criminal activity issues. Okay, the cut score that's been proposed by Hare is a score of 30, so that would be 30 out of 40. And I put in the standard error of measurement 3.0, and it'll be relevant when I talk about allegiance effect later on in the talk. So what are the factor 1 items? It's basically problems in the interpersonal world and also in the affect, in emotions, right? So whether it's glibness, whether it's pathological lying, whether it's shallow affect, when people talk about factor 1 items, this is what they're talking about. And if you, I know this talk is recorded, if you look back to some of the earlier slide or the earlier slide on where the overlap of antisocial personality disorder is with psychopathy, one of the smaller circles was also on factor 1 items, right? So this is what comprises the factor 1 items. The factor 2 items comprises the behavior and the criminal behaviors, right? But if you look at the debates of whether this is a true 2-factor model versus 3, certain individuals will say facet 4 doesn't actually should not be as heavily emphasized because the criminal behavior, they'll argue, is a byproduct of the problematic personality features, not necessarily a correlate, right? So again, behavior items versus emotional items. But if you are a student of assessment and measurement, I would say you'll probably get the sense that there are certain items within the behavioral realm that are simpler, easier to code than items in the emotional items, right? So whether someone had a history of early behavior problems, that's something that one can look at historical information and be clear on. Whether somebody engaged in delinquent behavior as a child is something that one can look at historical information on. If I scroll back to the factor 1 items, how charming does one need to be in order to have glibness, right? What is grandiosity based on my perception of what grandiosity might be versus someone else's? What is considered cunning and manipulative by my standard versus other? That you might sometimes run into some discrepancies, right? So when people talk about inter-rater reliability and where the problems occur, it's usually on the factor 1 items that have lower inter-rater reliability because it's harder to have agreement than scoring clear-cut behavior of whether it happened or not. So the items that are not on any of the 2 factors, but they're on the total PCL scores include sexual promiscuity, short-term marital relationships, and criminal versatility. Okay, and again, those are 3 items that just didn't load well using CFA models to those factors. But it's also 3 items they didn't want to throw away because it's much easier to measure those particular behavior outcomes, right? So in terms of what the current DSM-5 criteria are versus the PCLR ones and where you might be getting the information from, you'll see where the overlap occurs, right? You'll see the criminal facet or criminal behavior facet being highlighted multiple times. You'll be able to see the behavioral facet being overlapping onto the ASPD diagnostic criteria quite easily too, right? Where you're having fewer instances of clarity is the affective facets, right? So the lack of remorse is probably the one that's the closest, but it's very unclear how low empathy and superficial charm, even though it's included in the DSM-5 descriptions, are loading onto the actual criteria with which you need to make a decision, right? And that's where some of the differences may lay because the ASPD criteria might be more heavily geared towards behavior, right? If you think back to if 75% to 80% of individuals in forensic setting meet criteria for ASPD, I would question, well, how useful is this particular discrimination or this delineation, right? How useful is it if so many people meet this criteria by simply engaging in unlawful behavior? In terms of how did the PCLR become a very useful risk assessment tool, I sort of plotted out where the items may overlap when you're compared to the historical items of the HCR20, which is a structured professional judgment tool on violence risk, right? So if you look at the items that overlap and the information with which you score those items, you'll see that most of these you're going to be scored already, right? So in terms of, Collecting didn't intend for this to be a risk assessment tool, but the information that you're accumulating in order to understand whether individuals might have psychopathy is basically giving you a pretty good picture of whether it could lead to potentially violent behaviors as well, which is why, right, it's also one of the major useful tools for risk assessment, and this is violence risk assessment. This is also the same items, right? Same idea being plotted onto the VRAG, an actuarial tool for violence risk. So again, I'm not, arguing that those are better tools than others, but if we're using the same information to score one measure versus the others, and we know that the other measure is pretty good at discerning, violence risk, then there's a reason why the PCLR is a pretty good measure for getting a sense of violence risk as well. Okay, I'm sure that there'll be other questions regarding this, but violence risk assessment, right, is again a slightly different topic that probably warrants its own discussion and talk at a different time. I mentioned earlier that the PCLR screening version is probably a misnomer of sorts. And the reason is, if you look at the comparisons of the psychopathy checklist from its inception, right, to its revision, and now the screening version, there's some similarities, right? It is definitely a shorter measure, but if you look at the items that are highlighted in yellow, right? So the PCLR cannot be used with all offenders, right? It's used in adults and males, right? It has no female norms. So what does that mean? Basically, well, you can't really use it for incarcerated women, right? For this particular measure. And PCLR was really was really validated using prison inmates, right? So, and age 25 or above with lengthy records and also forensic patients. Whereas the PCLR screening version, there are actual norms for civil and forensic patients and can be used in community settings as well, right? So there is an argument to be made that it's actually a much broader measure with different norms, even though it's also a shorter version of the PCLR. So I see it's about the final 10 minutes, I'll get into some of the practical problems and also the implications. So one of the major controversies that arose within the past decade was this idea that the PCLR is a measure of psychopathy, right? But then we're confusing the construct and the measure. Calling something a gold standard has a problem, because then you have everyone only using the gold standard, which then results in a reduction in understanding of the construct. I'll show what the New York Times article is referring to in a following slide, but in one of the other problems that's been identified in the field is lower inter-rater reliability that is found in the field than in the initial validation, right? And that individuals who are trained within the same organization tend to have slightly higher inter-rater reliability than not. So then we kind of have a problem, right? Because I don't think all clinicians will be trained by the same individuals or be trained within the same organization. If you have the reliability and their inter-rater reliability continuing to drop, right, it would change the actual validity of these instruments, because we're relying on less reliable information over time. The allegiance bias I will also talk about, which is very impressive work by Dan Murray and Marcus Boccaccini. But basically, they were looking at whether individuals who are retained by one side of a litigation, whether you're retained by the defense or the prosecution, actually systematically bias how you score certain instruments. And the PCLR was one of those instruments where the expected difference in the scores, that's why I put in the standard error of measurement, was about 3 points. But we are consistently getting scores much higher than 3 to 6 points. That is only with the only difference being which side retained you. And one of the major studies that Murray and Boccaccini did, I think this was like might have been 2012 or 2013, when they actually experimentally designed a study where the only difference was whether evaluators got a call from the prosecution or what they thought was the defense, and they were asked to use the PCLR to raise, I think, 4 cases. So when you find a systematic difference that sustains over time, well, that's kind of a problem for the field, because, you know, integrity within the field, right, allows science to continue and makes the legal system also more trusting of what clinicians might be able to provide, right? Going back to the question of what is the clinical utility? Well, we want to be sure that the information we're providing is actually accurate. So this was the Murray and Boccaccini article on allegiance effect, right? And they call it adversarial allegiance effect. And can experts remain objective and accurate even when you are retained by one side over another? And by the way, this particular problem is not specific to forensic psychology or forensic psychiatry. This particular problem has actually persisted way into the forensic sciences, right? So we wouldn't expect a particular lab to give you, differing opinions depending on which side the lab use that particular lab to process things like fingerprints and DNA, right? But we are actually finding quite a bit that this particular systematic bias exists in the hard science as well. This is actually one of the few things that the social sciences actually called out much sooner, because we were more concerned about it based on what we know of our measures versus the hard sciences. And this was the academic battle that delayed the publication of articles. So this was around 2010 when Jennifer Scheme, right, was publishing a academic piece that was critical of the PCLR and Bob Hare, basically articulating that we're confusing the construct and the measure, that we can only use the PCLR as the only measure of psychopathy, because overly use of it then we have no other way of knowing whether we are advancing our understanding of the construct. Bob Hare was very upset by that. And he actually, I believe, delayed the publication of Scheme's article because he litigated against Scheme. And, the article from then, and there's also another back and forth that was opinion piece that was published by Scott Linenfeld articulating, hey, this is not what we do in academia, right? Like, the whole purpose of having research is that we can have conflicting opinions. And I think at the time, from what I remember, Bob Hare's argument was, this particular publication or the article is actually affecting my livelihood because he gets royalty for each time that the PCLR is used. So clearly there are multiple incentives at play, but this was one of the few areas in which a particular academic article, got pushed into the legal arena. So where is there agreements and disagreements on this particular topic? This particular topic meaning psychopathy. There's actually substantial agreement on the idea that there's a hierarchical structure. Okay, so there's no question that you have at least 3, if not 4, symptom clusters, right, represented by the various facets, and that it even Bob Hare, right, would say it's a continuously distributed in the general population, meaning at the time, if there's an argument of whether this is a categorical understanding of personality, whether the cut score is meant to be as useful, it's arguing that because it's continuously distributed, it suggests that it's not, we can understand personality or this at least construct in a dimensional way, and that psychopathy, right, represents an extreme end of that particular personality distribution. There's substantial agreement that it's actually kind of hard to figure out what to do with some of the intimate relationship items, and that they don't actually fit neatly into the factor structures that was into factor 1 or factor 2. So then the question becomes why, right? Like, if you have a theory that actually talks about how it affects people interpersonally, how come the intimate relationships factor don't map onto it so well, right? Where there's substantial disagreement is also whether criminal behavior is a correlate of these personality problems or a consequence, right? And is there even such a thing as secondary psychopathy? So secondary psychopathy was also a term that we used to see in the literature a lot more, that talks about psychopathic individuals or individuals who are prone to violence, who are prone to various problematic behaviors, and they're more reactive to then that they're more reactive. And so the question of then is there such thing as a secondary psychopathy? Because it seems to also mimic our understanding of borderline personality disorder, right? So then how useful is to distinguish between primary and secondary psychopathy when secondary psychopathy could be better explained by an already existing construct that we have, right? Okay, and on the measurement front, there is a lot of explanation as to whether the criminal behavior facet is useful or not to be included in the PCLR. And the measurement folks will say, if you actually remove facet 3 of the facet 4 of the PCLR, what you'll find is actually the validity correlates actually go way lower, right? So then if we remove the thing we can better measure, right, and the validity coefficients go much lower, then what are we actually measuring? Are we just measuring impulsive, right, unstable and violent behavior over and over again, and that is the thing that's driving all this? Or is it, as the theory suggests, we're having a hard time really pinpointing the hypo emotionality, and therefore we're having trouble consistently measure this particular construct. Okay, so as for implications for practice, the warnings are always don't overly interpret item scores, right? So the understanding of the total scores is always better than the factor scores or the FACET scores. In fact, the norms for the measures is on the total scores and the factor scores. There's no norms on the FACET scores or the individual items. And therefore, right, consistent with the understanding of measurement, we do want the things that actually suggest, hey, there's an overall elevation in all these areas, as opposed to, hey, there seems to be a lot of facet 1 items that are being elevated, and being overly confident that that is, indicative of a particular psychopathic construct. The second thing, implication for practice, is consider contamination of scores, right? So score contamination is when the same info is used to score multiple items. It's very, in fact, one of the reasons for using the worksheets when completing the PCLR is that it forces people to think more systematically of how they're coming to their formulations. You don't want to be biased by one event, right? Then is elevating all the scores. In fact, they'll say, make sure that you are using different points of evidence to score each of the items, so that you can be sure we're seeing right, going back to the definition of personality, we're seeing an enduring aspect of personality and not just one event that is actually causing all the items to increase. Okay, so I think wow, I actually finished 1 minute early. I know that I sped through a lot of the content, right? And again, the focus of the content is not to show you how to use the measure, because that will be doing it injustice. But any thoughts or questions that I think you can type into the Q&A. Anthony will, hopefully do a good job of summarizing and asking me. And if there's other questions that you'd like to email me separately, my email is included. And so hopefully that should suffice for now.
Thank you so much, Wen, for that thorough crash course in a lot of different issues related to psychopathy. We do have several questions already. If you have any additional questions, of course, anybody that's in attendance, go ahead and add those into the Q&A box. I do see a lot of common threads in some of these, so I might integrate some of them together.
Yeah.
Throughout the talk, I think it looked like a lot of people were hearing you talk about different facets of psychopathy, and this question came up several times across the talk about, people seeing overlap potentially between the construct of that and autism spectrum disorder. So I was going to read one question here and get your thoughts on this. What is the best way to assess whether an individual has autism spectrum disorder versus psychopathy? So they share same social emotional deficits related to lacking understanding of empathy. There seems to be a lot of individuals with autism spectrum disorder who are missed when they have delinquent traits. They also ask, what is the comorbidity of autism spectrum antisocial personality disorder? I don't see much overlap in my clinical practice, but want to know more.
Okay, it's so very good question, right? So the question of autism, strangely, actually comes up with also when people ask about psychotic disorders, right? Because one of the 4 A's of schizophrenia, if you remember Bueller's point, that one of the A's was autism, right? So depending on what one is talking about with respect to autism, when you see developmental traits happen much sooner on, there's a difference. I think what actually makes this all complicated is whenever you have a youth that's engaging in more delinquent behaviors, you sort of get this giant mess of, bad things tend to correlate with each other, right? We know that from studying social economic status, from studying, how people tend to do, what are the trajectories of individuals who are born higher SES versus low SES. Good things tend to correlate together, bad things tend to correlate together. So my sense in this is that autism spectrum disorder, it tends to be diagnosed much sooner on than anything like psychopathy, right? Because if you think about the trajectory of developmental disorders, we really don't consider psychopathic personality as an enduring aspect until people are into their adolescence, into their early adulthood, right? So the really emphasis is on the enduring. The enduring part, and also the psychopathic. It's not just that within the definition of autism, there's a lack of social reciprocity, right? And almost this disinterest in interacting with individuals. This is not what this is talking about. In fact, you might actually have people who have some interest in interacting with people, but for a very different purpose. It's not that they don't like to connect with people. They often do so because the deficits are there. And so if you get into the actual definitions of, are we talking about youths who have no interest or have little interest in seeing the value of social interactions, versus on the more psychopathic realm would be, I am interacting with people to achieve a specific goal that is very unique to me, right? So that's a very different understanding of why this is happening. I would say autism is one of the, you will see autism being considered in the diagnostic rule-outs much sooner in that youth's life as opposed to psychopathy. That would be my best way to answer that particular question.
Wonderful, thank you. A couple of people asked about the construct of hypoemotionality. One wanted just a general overview of what that is broadly, but then the follow-up to that is, with the criterion of hypoemotionality, how does one discern cultural differences in emotional expression?
I think that's probably one of the hardest things, right? So I've talked about section 3 of the DSM-5, right? Believe it or not, the DSM-5 cultural formulation model actually does a pretty good job of incorporating culture into a lot of the diagnostic interviews in the formulations. So to the question of how do you consider it, you have to know what is the norm if we're talking about a very different culture altogether. And it's actually been, I've actually seen a few, if you look at the work of Tess Neal, right, who was basically looking at when clinicians use a measure, right, beyond what it's designed to do. So I think in her example, she was looking through law cases where, or case laws where you had one clinician who basically used the PCLR for a population that we have no norms on, right? And then concluding about this particular person's, likelihood of reoffending, which is completely out of bounds. And then when as she read through that particular case law, it seems like the judge and that case seemed to not care that particular much. So it kind of created this situation where clinicians and the measurements folks are very concerned about, hey, let's make sure we're doing the right things, and we're doing things within our expertise and competence and knowledge. And sometimes the legal are going, we trust you, and probably overly so. I don't know if I answered that question in the intent that it was asked, but with respect to I don't think it's possible to understand the construct of psychopathy outside one's culture. But as you see in the 1976 Murphy example, there is an acknowledgement of there's a small group of people almost within all cultures who seems like people have enough of an inkling that they're having a hard time with correcting their particular behaviors, right? So if you think back to the slide that I had about what happens when one has low anxiety as an adult and as a child, chances are you're relying on more of the trial and error approach to figuring things out, to learning, right? So it takes longer for some of the for a child to figure out, okay, this particular approach that I have for dealing with parents or dealing with school is simply not working because I don't get the same response from the risk and reward implications. It might take longer, right? And there's a recognition that there are folks who it just the same rules apply to the same individuals are not yielding the same results.
Pivoting a little bit on this cultural discussion of psychopathy here, several people asked about gender issues as it relates to understanding psychopathy. One question in particular was, most studies on antisocial personality and psychopathy are completed with predominantly male subjects. How would you say this skews our description of psychopathy and thus our ability to recognize or diagnose psychopathy in women?
I think our understanding of psychopathy in women is thoroughly lacking, right? For the very reason that we talked about. If you looked at Cleckley's theory of this phenomenon, there's a lot. In fact, I think a third of the case studies that he included in his book were about young women. It was not predominantly men, right? And he was getting his samples for the case studies, not in incarcerated settings. So absolutely, our understanding of psychopathy has changed because we're overly sampling from correctional samples, right? And I mean, I think if I look at the most recent APLS conference brochure, right, and I go through some of the topics of how it's being studied, I think there is an attempt to try to understand certain potentially psychopathic behaviors within the white collar world, right? Where there's a question of when people engage in really difficult decision making within the corporate world, is this psychopathy? And the question is, I don't know. We don't have a good understanding of psychopathy outside of it in the way that it's measured. I completely agree with the comment that our understanding of psychopathy ought to be more general than the way that it's been studied. Right. But then the question becomes, how do we get those samples?
Always a challenge, representativeness in a lot of these constructs that we try to assess.
Oh, yeah. And just another kind of point about there's no such thing as a normal, the average psychopath does not exist. Right. It's not something you want to give the sense of, oh, the typical psychopath or psychopathic person engages in this behavior or does these things. There's no such thing because we are already studying this phenomenon at the extremes of a distribution. And whenever you get into the extremes, everything becomes more difficult to discern.
How do you consider trauma within presentations of psychopathy? Research shows that acquired callousness, for example, post-traumatic overmodulation, callous unemotional traits associated with trauma, is highly associated with extensive childhood trauma.
I mean, I hope that it would be one of the items that there is room for it. I know on the HCR20, when it's talking about whether one is more prone to engage in more, it's one of the historical risk factors on the HCR20, right? So whether one has experienced being a victim of trauma or one has caused trauma. I think it all goes into the understanding of we had an experience with this particular person, right, that resulted in certain facets or certain traits being more solidified. So is it more likely that those individuals engage in more delinquent or certain behaviors? I would say not necessarily, right? Like, so with anything, I would say you're probably you're going to find individuals who've had experienced trauma that don't engage in such behaviors or outcomes more so than engaging in such behaviors. Meaning, like, it's still a low base rate phenomenon. I think the base rate that even some of the recent studies say, you probably have 1 in 150, so about somewhere between 0.5% to 0.75%. So when we're thinking about psychopathy, you have to think about it within the overall decision tree of our understanding of psychopathology, right? It's not a high frequency or high frequent event, and therefore our understanding of the phenomena ought to match with that as well.
So kind of related to that you're going over, somebody brings up the specific example that they have found inmate after inmate diagnosed with antisocial personality disorder who had remarkably traumatic early childhood experiences, as well as gang membership and affiliation, without ensuring their behavior or affect weren't more appropriately related to trauma or culture, and that this obviously affects treatment planning. How would you address this concern?
Great question, right? Tough to answer. I would say, what criteria are you using for that particular diagnosis for ASPD, and for what purpose? Okay, so if you're saying treatment planning, are you so, like, if we're going to the more general question of is this individual interested in treatment? I think if we're talking about clinical treatment in the traditional sense versus in the court mandated sense, you still need therapeutic alliance. You still need somebody who's interested in even receiving what you have to offer. And maybe for individuals who've gone through some trials of trial and error, and even if the goal is, I don't want to get arrested again, right? Find me a better way so that I'm not getting caught. That's not. I mean, there's a way for a therapist to work with that so that there's some alignment. I would say, the diagnosis of ASPD, I think it's not particularly helpful if we're talking about individuals who already have a long history of incarceration. And I go back to what is it that the person wants, right? Like, that's the only way I can think of it where it's not a court ordered or court mandated treatment where the incentives are different than what the person might actually want.
Since we've gone past the top of the hour, I'll ask one more question here to wrap all of this up. And I think it gets at kind of this meta view of assessing this period. Going back to the utility of assessment, wouldn't identifying psychopathy and the severity in an individual for the purpose of sentencing punish an individual for their mental health functioning? I've had this debate with others before.
I mean, absolutely, right? I think there's a question as to whether it is a good enough of a tool to use for sentencing purposes. I think that is a debate that is certainly warranted as our understanding of psychopathy increases, and also knowing the limitations of these particular instruments. So this is not this is just my personal opinion now, right? My opinion is, know the limitations of the tools that we use. Sometimes the legal system might overly index on how useful some of these tools are. I would say it's always more cautious that we shouldn't be using a tool beyond its means. I don't know whether using it for sentencing purposes is a good idea. In fact, I would be open to saying I don't like to think of it as something. I don't think the clinical utility is there for us to be able to use it for that purpose. I think it assumes that the measure is way too precise and its predictive nature is way too valid for what we're using it for. I don't think we know it that well, especially if we're talking about sentences that are 10, 20, 15 years, right? Like, we can see people change rapidly. I mean, we whether not rapidly, but we can see people change over that time. And so I don't think it's a good idea to use an instrument beyond what our knowledge of the instrument is.
Dr. Gu, when can I say it's been a pleasure, and thank you so much for sharing on a number of different facets, theoretically, conceptually, practically, on how we might understand and consider psychopathy and psychopathic personality traits. Very much appreciate your expertise here.
Great. Thank you so much.
Absolutely. That wraps up this week's Law and Mental Health series. We hope to see you again soon. And until then, take care.